Hello, good day to everyone. My name is C.B. Mamaril, and on behalf of the Systems for Action National Coordinating Center, I'd like to welcome all of you today to S4A's Research in Progress webinar on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. We're excited that we have a great topic with us today on housing for health, cross-sector impacts of supportive housing for homeless high users of health care. Before we get started, I'd like to first acknowledge the funding and support of the Robert Wood Johnson Foundation, and we would also like to encourage everyone that if you have any questions for our presenters or our commentary speaker today, that at any time during the presentation or webinar, you can type your questions in the chat box on the lower left-hand corner of your screen. Without much further ado, let me first introduce our presenter for today, Dr. Ricardo Basurto Davila, who is a health economist at the Los Angeles County Department of Public Health, where he is the Chief Executive Officer of the Policy Analysis Unit. Ricardo's work involves economic evaluation and quantitative analysis in general of programs and policies in public health and other sectors that affect health outcomes. He previously was a Prevention Effectiveness Fellow at the U.S. Centers for Disease Control and Prevention and an Assistant Policy Analyst at RAND Corporation. Our commentator for today is Ms. Whitney Lawrence, who, as Director of Policy and Planning, leads data and evaluation efforts at Housing for Health and oversees the Flexible Housing Subsidy Pool, a local rental subsidy program focused on providing permanent supportive housing for individuals experiencing homelessness in Los Angeles County. Prior to joining the county, her work focused on systems of change efforts to end and prevent homelessness for people with a history of incarceration and homelessness in Los Angeles. Whitney earned her master's degree in public policy at the Hubert Humphrey School of Public Affairs. So with that, I'd like to turn it over to you, Ricardo.
Thank you, Sydney. Just a quick clarification. There was a mix-up with my bio that I should have got earlier. I am not Chief Executive Officer of unit in the Department of Public Health. I used to work for the County Department of Public Health, and now I work for the Los Angeles County Chief Executive Office. So just I mixed up in my.
Sorry.
No worries. I should have got that earlier. Just wanted to make that clarification. I want to thank the Systems for Action program for the invitation to give this talk, for their support as well. I guess so we can switch slides and acknowledge the Robert Wood Johnson Foundation for the financial support of this research. Of course, Systems for Action National Coordinating Center, they have been great in aiding us to get this work done. The disclaimer, the views you're going to hear today in the presentation do not necessarily reflect the Foundation's views. So let me get started with a little bit of background of why this is important, particularly in Los Angeles County. Some of you may be familiar with this point-in-time estimates of homelessness that are released every year by the Housing and Urban Development Department. As you can see, the two lines we have in this graph, the red one is for the United States. The numbers are on the left axis, and the blue line is for Los Angeles County, and the numbers, the point-in-time estimates, are on the right axis. Over the last decade, we have seen a downward trend in the number of homeless in the United States, although that downward trend sort of stalled the last couple of years, but still we see a significant decrease from nearly 650,000 to just over 550,000 individuals who are homeless on any given day in the U.S. On the other hand, that trend unfortunately has not been replicated in LA County. And if we have the line for California, it looks fairly similar to LA County, so it also looks upward. We have seen a mostly constant increase over the same decade in the number of homeless in LA County, such that the latest estimates were of about 50,000 individuals. And moreover, what I'm showing here is that LA County has by far the largest number of chronic homeless in the U.S. and also particularly unsheltered homeless, which creates additional policy complications, obviously, for our work. Oh, goodness, the slide was supposed to be before. Sorry, I just want to quickly acknowledge we have a large team conducting this study. First, the county's research team from the Departments of Public Health, Health Services, and the Chief Executive Office. We had a team from UCLA conducting some of our qualitative analysis. And we had a large number of collaborators, obviously the Housing for Health program, other county departments, and everybody who participated in our qualitative data collection. Apologize for the wrong order in this slide. So this is the outline of our talk today. I mean, we first, want to give this quick introduction of why we care about homelessness, particularly when it comes to health and the multiple sectors. Then we'll talk about permanent supportive housing, which is the current cornerstone of the policy to combat homelessness, particularly chronic homelessness. Then we'll introduce the Housing for Health initiative here in LA County and why we think that it constitutes a promising model to improve outcomes for homeless individuals who receive services through a permanent supportive housing model. And we'll conclude with the findings of our study. So I showed you why in LA County we care about homelessness, but many of you may be here because they're interested more in homelessness and health and what those impacts are. Homeless populations, there's plenty of literature that has shown that homeless individuals are at higher risk of a number of types of illnesses, including acute illness, chronic diseases, mental health disorders, and in summary, they are much more likely to die prematurely. But obviously, these health issues, because this is a population that has trouble accessing health systems, then it also results in significant access, significant gaps in how they use healthcare services, inappropriate use of healthcare services in particular. Homeless populations rely heavily on emergency department visits. That's not how we want people to get their healthcare. And they experience high rates of hospitalizations for preventable conditions. So this results both in inappropriate uses of healthcare services and also in high costs for the healthcare sector from the use of services by this population. But this is a problem not exclusive to the healthcare sector. Homeless individuals have contact with multiple public sectors. In addition to health services, they also have frequent encounters with the mental health services sector, with substance use treatment, with public social programs, in particular income support and food support programs. And finally, they have also significant, frequent encounters with the criminal justice system. So, in summary, this is a system-level issue. Homelessness, I think most of you are here because you're interested in the impact of homelessness in healthcare and maybe the role that public health or the healthcare services sector can have on improving outcomes for homeless population. But for us in LA County, we clearly see this is a system-level issue that affects not only the health side, but also affects multiple other sectors in the county, and that the solutions to this problem probably need to be applied at a system level. A couple of years ago, two analysts here at the Los Angeles County Chief Executive Office did a study of the total cost of providing services to homeless individuals in the county across 6 different departments. And this table summarizes the findings. I guess the punchline is the second to last row that they found that in fiscal year 2014-15, the county spent nearly $1 billion providing services to homeless individuals. As you can see, these costs were distributed widely across the department. There are 3 departments that spent more than $250 million in 1 year servicing homeless individuals. And we see involvement across the criminal justice system, public health, mental health, health services, and social services. I want to highlight 2 things in this slide. One is, as you can see, the total number of unique individuals served across all these departments was nearly 150,000. If you recall 2 slides back, I showed us that the point-in-time estimates for number of homeless in LA County was about 50,000. So this highlights one of the issues with the point-in-time estimates. That only means that on a given day, there were roughly 50,000 individuals who were homeless in the county. but there are 365 days in a year. And so as we can see, the total number of homeless individuals, this is a lower bound estimate because these are only the ones who receive services through any of these county departments, but there were probably even more homeless individuals who didn't receive services through these departments, or maybe just did not identify themselves as homeless. So bottom line is, there are a large number, much larger than the point-in-time estimates suggest, of individuals who experience homelessness at least at some point during every year. The second thing I want to highlight is the last row, where if we look at just the top 10%, the highest utilizers of services, which are just under 15,000, they accounted for more than half of these expenditures. So it's $500 million of these expenditures that are accounted for by only 15,000 individuals. And as you can see, the average annual cost to the county of those high utilizers was more than $30,000. So obviously, this is an issue that indicates if we are able to intervene, help these individuals improve their housing stability and maybe improve their situation in these other sectors, we not only can help them improve their lives, but we could probably take a big chunk out of these expenditures and use them on something else, improve services for many other individuals in the county. So like I said before, the current sort of cornerstone of in the policies to combat homelessness, particularly chronic homelessness, is permanent supportive housing. And permanent supportive housing is basically an intervention model that combines three key elements. First of all, is providing permanent housing. This is not temporary. This is giving someone housing where they can stay just like a regular renter, that as long as they keep paying rent, they can remain housed as long as they need it. The second element is rental subsidies, so they can afford to pay for this housing that they're given. And the third element are voluntary supportive services that include, services such as independent living skills, tenancy skills, paying rent, how to pay their bills, etc., and perhaps more importantly, or just as importantly, connections to other services they need, such as those in health, social services, income support, and other community-based services. So each of these elements is really key to ensure that people are able to remain housed and that they improve their conditions across many different domains in their lives. There is plenty of evidence that permanent supportive housing is effective in keeping people housed, and that it also has positive impacts in some sectors, such as healthcare, for example, and improving the utilization of healthcare services. But at the same time, there's some gaps in the literature on the impact of permanent supportive housing. There are only a handful of studies that have analyzed the impact of permanent supportive housing programs across multiple public sectors. If you look for this literature, you may find a study that looked at healthcare services, others that looked at the impact on mental health services, etc. But few studies have actually taken a holistic view of, okay, how does a particular permanent supportive housing program impact service realization or outcomes across multiple sectors in a single study. Moreover, a study published by the National Academy of Sciences last year, this is a consensus report by the Academy, found other significant gaps in the literature. Most importantly, there seem to be significant inconsistencies in the definitions of what permanent supportive housing constitutes and also the characteristics of permanent supportive housing programs. There's also very limited understanding of what are the standards for supportive services. So what specific services are actually provided to clients of these programs. Finally, they also found that the data systems that we have in place right now do not allow for integrating the data on homeless, health, and other sectors, and so makes it very difficult to evaluate the impact of these programs on a system-level scale. It's much easier to evaluate the impact on housing outcomes than on health or substance use treatment, for example. So they also concluded that there is a need for better analytical methods because many of the existing studies have used just pre-post methodologies that are subject to a number of biases. I encourage all of you to read this report. It's fairly comprehensive and it highlights the many gaps that we have on this literature. And fortunately, our study, which was started more than a year before that report was published, fortunately we believe our study addresses some of these issues. So what is Housing for Health? Housing for Health is an initiative that was created in 2012 by the county's Department of Health Services. And at the time, the goal of the program was to provide permanent supportive housing to high utilizers of publicly funded healthcare services. So essentially, high users of this department, who were also homeless. The goal of the initiative was to provide housing for them in order to reduce homelessness, to improve health outcomes, of course, among their patients, and to reduce inappropriate use of healthcare resources. As we saw before, by improving the use of services, they expected it would also reduce costs and thus reduce inappropriate use of resources. I should say that since the program was created, they have expanded this goal to providing permanent supportive housing not only to high utilizers of healthcare services, but to the broader chronic homeless population in the county. But through the period that we analyzed in this study, the goal of the program was still to focus on high utilizers of healthcare services. So how is Housing for Health different from permanent supportive housing programs? Well, you can see in this slide some of the issues that exist with the current normal representative, implementation models for permanent supportive housing. One of the key issues is there's fragmentation. There's no lack of coordination in the management of the three different components. The housing provision, supportive services, and rental subsidies are not really coordinated by any dedicated staff or any organization. These things are usually provided separately, and so it's either clients that sometimes have to navigate each of these and try to find housing on one side, receive supportive services on the other side, or find subsidies somewhere else, or sometimes if they have a case manager that's helping the client, still the case manager is tasked with figuring these things out in many different places. This also creates a lack of oversight in the activities of housing managers, service providers. Nobody's actually taking a look at what they're doing, what kind of services they're providing, are they providing them properly. It makes it difficult to set also standards for supportive services, so it is not uncommon to see very high ratios of clients to case managers. It's also not always clear what skills are required or that support that service providers require among their staff for providing these services. And finally, with something that's also critical, there's significant fragmentation in the funding of supportive services. So service providers often have to spend a lot of time just making sure that they have the money, the funding to provide their services and continue serving their clients. And this lack of funding also often leads to these high ratios of clients to case managers. On the other hand, on Housing for Health, what we see, first of all, is they centralized the administration of all three components. They have dedicated staff within the initiative who are responsible for working with housing, the organizations looking for housing. They contract with service providers, and they also pool funding from many different sources that they themselves manage to be able to provide subsidies to the clients of the program. This allows for centralized oversight of every single component. So this dedicated staff, they're paying attention to what providers are doing, to housing managers, what they're doing, and their weekly reports of activities so they know what services are being received by each of the clients of the initiative. And it also creates some standards in the provision of services. For example, they have a requirement of a maximum ratio of 20 clients per case manager. They have minimum requirements for the providers and what services need to be provided to the clients. And they also have pooled multiple funding sources under a single initiative. So they have funding for, they pull vouchers from the federal government, vouchers from the Veterans Administration, from other sources that they manage them and they provide to the clients depending on their eligibility. And in addition, they created a flexible housing subsidy pool so that individuals who may not qualify for any other sources of funding, they still are able to receive funding for rental subsidies directly from Housing for Health. So this is money coming directly from the Department of Health Services General Fund. In short, this slide, I'm just trying to summarize what I described before, is Housing for Health coordinates, integrates the activities of these three different components, and puts them all under the umbrella of an organization that is in charge of monitoring their activities and ensuring that the services are provided properly for the clients of all these three types of services. So in our study, what we're basically trying to do is ask the question, does this approach to implementing permanent supportive housing work? Does it improve any of the outcomes? Because at the end of the day, by creating this extra structure, by centralizing the administration of these components, there are some extra costs. There's extra work that needs to be done to be able to implement permanent supportive housing this way. So we're asking questions, does this work? Do they achieve their objectives of improving housing outcomes, improving health outcomes, improving the utilization of healthcare services, and maybe also improving utilization of services in other sectors and reducing involvement in the justice system? I should say, as we will see later, we were not able to answer the question of the impact of the program on health outcomes because we only were able to receive data on healthcare utilization, but not on actual outcomes. So we do not have, for example, lab tests or other data that we initially intended to use in the study. But we can certainly, we're able to provide answers for all these other questions. And finally, one other question, obviously we want this to be valuable for the program, so we wanted to identify opportunities for program improvement. Our methodology for this study, we used a mixed methods approach. We have some qualitative data collection and analysis. We did significant quantitative analysis of administrative data, and we also developed a simulation model that allows us to answer what-if type of questions for different policy changes. So I'm going to now walk you through the methods and the results of each of these components of our study. First of all, we contracted with the UCLA Center for Health Policy Research to conduct qualitative data collection and analyze this data. Our goal for this component of the study was just to get an insight into the perceptions by clients of Housing for Health, clients of other permanent supportive housing programs, similarly service providers both in Housing for Health and other service permanent supportive housing programs, and also just other stakeholders in the system, for homeless populations. Like we want to get a sense of what the perceptions are regarding permanent supportive housing in general, and more specifically on Housing for Health's approach to implementing PSH. To do this work, the UCLA team conducted 9 focus groups, including 42 clients of Housing for Health and other permanent supportive housing programs, 29 staff of service providers for both Housing for Health and other programs, and also they conducted key informant interviews with 14 stakeholders, either senior staff of agencies that provide permanent supportive housing programming, and also of other agencies in related public sectors, health, housing, and other sectors. So what did they find? So what they found is, first of all, key informants essentially confirmed what was reported by the National Academy of Sciences, that there is significant variation in how permanent supportive housing is implemented. This variation often, one of the most common comments is that the availability of resources varies significantly. There are some programs where providers have a good number of staff. They have staff that is highly qualified, and there are other smaller programs that are struggling to just get funding to provide their services, or that maybe their staff are not as qualified as those in other programs. The capacity, the skills of the staff, the funding sources, the mechanisms, all of these many issues that were also found by the National Academy of Sciences, we essentially see that something similar happens in Los Angeles County. Of most concern, as you can see in the last bullet, that there was some concern that some programs may not actually meet the fidelity requirements established by SAMHSA for permanent supportive housing. So the participants in our qualitative analysis, in terms of what distinguishes Housing for Health from other permanent supportive housing models, they also provided support to the premise that we have in our study, that it is the vertical integration, the centralization of management for all elements in the program that distinguishes Housing for Health from the more other approaches to permanent supportive housing. Participants also highlighted the requirements of the program. This 20-to-1 client case manager ratio, they think it's critical for improving services. And this reporting, electronic reporting of all activities of service providers on what services they're providing to each client. What they also highlighted is just the dedicated availability of funding for supportive services that it allows service providers to do their job providing services rather than spend too much time trying to get funding from other sources, like applying for grants or something else. That they have money that for every client that is involved in Housing for Health, they know that every month they get a fixed amount of money for that client without needing to go hunt for it from other places. Participants did identify a couple of potentially negative impacts on Housing for Health, although as you can see in this slide, the message was essentially providers are having trouble keeping up with the growth in the program. As you will see in a few slides, Housing for Health has grown very fast since it was created in 2012. They're enrolling, thousands of new clients every year, and service providers are just struggling in their hiring and their practices, to keep up with this growth. And of concern is that perhaps not all providers, there was some concern among our stakeholders in our interviews that not all providers may be implementing Housing for Health models with fidelity. So there's some concern here that maybe this rapid growth is creating some strains in the systems and in the capacity of providers. Regarding the impact of Housing for Health on outcomes of clients, in general, the perception by participants in our qualitative analysis was that the program is having a positive impact, obviously because it is a program managed by the Department of Health Services. Much of the focus of the conversation and their opinions was that the program indeed facilitates access to medical care, mental health services, and also because of the dedicated, the centralized management of some of these services, it also facilitates access to other county departments. They also, the opinion was that it decreases detrimental behaviors such as substance use or criminal activity, and moreover that the program has other intangible benefits that we were not really addressing in our quantitative analysis. So it was very valuable for us to see this mentioned in our qualitative data collection. For example, they mentioned that for some participants in the program, being part of the program allows them to reunite with their families. And in some cases, the only barrier to a parent to be reunited with their kids is to have housing, and by participating in this program and being housed, then that allows them to be united with their families again. Some other intangible benefits that they mentioned is, unfortunately, we do have a higher mortality rate among this population, regardless of their participation in this program. And but what we heard is that being housed allows some of the clients to die with dignity, which of course is also important. So for our quantitative analysis, we used linked administrative data from several county departments. We're very lucky in Los Angeles that the county's chief executive office for many years has had this integrated data system called the Enterprise Linkages Project, which integrates individual level data across multiple departments and over time. And you can see on the bottom left of the slide the departments that we used in our analysis. So we were able to link individuals across all these departments and look at them over a number of years. We combined Enterprise Linkages Project data with administrative data from Housing for Health, which allowed us to identify Housing for Health clients in all these other data systems. The way this works is the county chief executive office does a probabilistic linkage of records across all these departments' data systems. They create a unique identifier for all of them. They remove the personal information, and we received the identified data set where we can still see each individual across all these systems. Our approach, well, first of all, the goal of our analysis in the quantitative analysis was to examine how Housing for Health affects utilization of public services across multiple sectors, all these sectors listed in the previous slide, and also the involvement with the criminal justice system. To do this analysis, we did a difference in differences regression analysis. We were comparing Housing for Health clients to a sample of clients of other permanent supportive housing programs in the county. And what we do is we compare service utilization and criminal justice involvement 1 year before being housed to 1 year after they're housed, either in Housing for Health or through the other permanent supportive housing program. Obviously, by using a difference in differences approach, we'll improve upon much of the existing literature, which relies only on pre-post comparisons. By doing difference in differences, we're eliminating a number of biases to which those other studies are subject to. As I mentioned before, Housing for Health has grown very fast. You can see in this slide, the blue line represents the number of people who were enrolled in the program at each point in time. And the red line is the number, the clients who, after enrollment, were placed into housing. A couple of things I want to highlight in this chart. First of all, as you can see, the vertical distance between these two lines keeps becoming wider. What this reflects is the issue that now it's not only service providers that are struggling to keep up with the program, but the availability of housing units is now becoming an issue. They have more and more people enrolled, and as soon as they're enrolled, these people are receiving case management, they're receiving supported services, but it is becoming more difficult to place them into housing precisely because there are not enough units available in the county, and it's taken longer to house them. This also shows that there's not sort of like a one-stop solution to homelessness, even though this program is addressing several issues that exist in these types of interventions. You know, we also need to cover the side of increasing the availability of housing units so that these two lines will start becoming closer once again and people will get housed faster. The second thing I wanted to highlight, you can see two lines that intersect around July of 2016. That shows the data we're using in our quantitative analysis because we have a 1-year follow-up. We had data through July of 2017, but we're only using data for clients who enrolled through July 2016 so that we can follow them for a whole year after they moved into housing. So what did we find? First of all, permanent supportive housing, and there's plenty of evidence on this, it already does an excellent job in keeping people housed. So if an individual receives housing through any permanent supportive housing program, they have an excellent chance of remaining housed 1 year after they moved in. This was also what we found in our analysis. For the data we had from other permanent supportive housing programs, we found that they have 92% retention rate 1 year after moving in. We still found that Housing for Health improved slightly over that. So the Housing for Health had a 96% retention rate among their clients after move-in, 1 year after move-in. From this analysis, we did exclude individuals who died or those who moved on to other types of independent permanent housing that would not really constitute a dropping out from the program. We also found that Housing for Health, even if it did not, obviously there was not much room for improvement in terms of housing retention, but how about its impact on other sectors? Well, first of all, we found very strong impact of Housing for Health in reducing healthcare service utilization across multiple types of services. And let me walk you through how to read the numbers in this slide. We have in the second column estimates for how Housing for Health affects the percent of clients who use any services. And these numbers, for example, the first one with the 54%, what it means is, the way to interpret it is, if all of Housing for Health clients have been enrolled instead of in Housing for Health, had they been enrolled in a different permanent supportive housing program in LA County, then we would have expected 54% of them, 54% more of them, to be using emergency room services. The column on the right side is for estimates on the number of visits. So had a Housing for Health client, instead of being enrolled in Housing for Health, had been enrolled in another permanent supportive housing program, we would have expected that person to use 52% more emergency room visits than what they experienced by being enrolled in Housing for Health. All of the estimates, most estimates in this slide, as you can see, are highly significant. When they're significant at the 0.001 confidence level. So what this represents is a fairly large impact of Housing for Health in reducing healthcare utilization across all domains, particularly emergency rooms and inpatient visits, and also reducing the average number of visits in both emergency rooms and inpatient visits. We see also a smaller reduction in the number of clients using outpatient services, but we see no impact in the number of visits, outpatient visits, which is probably a good thing, because at the end of the day, what we're trying is to shift healthcare utilization away from acute services and towards primary care. So we're glad that we see that even though the program may reduce outpatient visits, perhaps because the clients are healthier, but it also does not significantly reduce the number of visits, because we want them to be regular uses of primary care services. So overall, we see that all the visits across DHS are reduced by 40%. The number of clients using DHS services is reduced by almost 40%, and the number of visits is reduced by about 30%. We see a similar pattern of results for mental health services. We see significant reductions in the number of clients that use emergency and inpatient mental health services, as well as on the number of services used by these patients. But in this case, we do not see any impact in outpatient services. And again, this is a good thing. We want individuals to be stably engaged in the use of mental health services if they need them. And here we do not see any evidence that there is a reduction in the use of outpatient services, only in the use of acute emergency services. And also, as you can see, our estimates have actually increased in the use of these services, but they were not statistically significant. This increases in use of services, mental health services. On the other hand, we see a mixed impact of the impact of Housing for Health on other public sectors. We do not see any statistically significant impact in the use of substance use treatment, and we also do not see any impact on the use of income support programs. I should clarify, the data we had for income support was very limited. It was only for the General Relief, which is a program funded by the county to provide income for individuals who do not qualify for anything else. So unfortunately, we did not have data for programs such as Social Security disability or other income support programs where there may also be an impact, but we will not have that data available. We did see, and we think this is very important, a significant decrease in involvement with the justice system. We found that the program reduced the number of clients who spent any time in jail during, again, the year following the move-in date. And we also see a decrease of more than 50% in the average number of days that this individual spent in jail. So this is obviously huge, another really positive impact of the program on outcomes for its clients. Finally, our study, as I mentioned before, part of our study was developing a simulation model to develop a more comprehensive understanding of how Housing for Health, or in general the systems of care for homeless, affect service utilization and outcomes across public sectors. The reason we did this, the simulation model, is because rather than bringing it, like I showed you in previous slides, this separate estimates of how the program affects services in different sectors, we want to understand also the synergies that this can have. So we believe by improving mental health outcomes, that may also be having an impact on criminal justice, and by improving the criminal justice involvement, that may also have a separate impact on use of social services or health services. So we wanted to develop a comprehensive view of how all of these systems interact together. Now, we analysts, particularly those of us involved in this study, we're not experts. We don't have the depth of subject matter expertise on any of these sectors. And even stakeholders who are involved in each of these sectors, they have only partial understanding of how their sectors operate. They may understand very well how the homeless interact with the healthcare system, but the same person may not have the same understanding for interactions with justice or substance use treatment, for example. So the way we access this is by using a participatory approach. We convene the number of stakeholders across all these different systems, and we work with all of them in a single session to try to develop these pathways, understand the pathways that homeless individuals take through different public sectors, and understand how public intervention, how different programs, different departments can affect those pathways. And so, as you can see, we have here some pictures of that convening of stakeholders that we did. This was sometime last year, or maybe actually a little more than a year ago. This is the result. Bear with me. This is what we developed as a result of that participatory approach. This is the structure, what is called a fuzzy cognitive map systems model, the result of our participatory approach. And what we have here, again, are the pathways that individuals can take across multiple sectors in the county. We have social services, we have healthcare services, mental health services, substance use treatment, criminal justice involvement, of course, housing, supportive services, case management services, all of them represented in this model. And this is this picture represents all the different interactions. I'm not going to try to walk you through everything in the model. Just maybe if you're curious, the blue lines represent things that have a positive relationship with each other, that if you increase something, then increase the other nodes. Red lines represent two nodes that have negative relationships. Maybe an easier way to show you how we can use this is if we extract some pieces of this diagram, then we can sort of represent what is known, I'm sure many of you are familiar with the revolving door in the criminal justice system. And this is essentially a vicious cycle that shows that for certain people who have uncontrolled chronic or mental health or substance use problems, then those people experience this vicious cycle that gets them continuously in touch with law enforcement, which results in arrest and incarceration, which creates more stress and trauma, makes it difficult for them to manage their conditions, and that, again, results in more contact with law enforcement. And so this revolving door is well known in the policy arena. It is one of the reasons why many of these programs that are created are trying to eliminate it. What our simulation model shows is that without public intervention, it is very difficult to break this vicious cycle. But by creating public intervention through supportive services, by providing case management, then we can help these people get out of this vicious cycle and enter a new pathway that will help them resolve their issues and then reduce their involvement with the justice system. So this is just one of many insights that we get from the simulation model. And obviously this is not something that probably we all understand. It's intuitive that this can happen, but the value of having the simulation model is that we can create estimates of how this affects different types of interventions affect this revolving door, and maybe what combination of interventions would be most effective in reducing justice involvement. I know I'm running out of time. I've not already run out of time, but this is just another example of what we can do with the simulation model. So if we simulate a policy where we're increasing the availability of permanent housing and we're also providing rental subsidies, so essentially we're replicating what Housing for Health does, then these are estimates of the impact across many sectors, including housing, health, justice, and also costs to the agencies in all these different sectors. And the estimate, as you can see, is some sort of standardized measure of the intensity, the strength of the impact across all these different sectors. So we're very excited of having this simulation model that allows us to run different combinations of policy interventions and see what the impact would be. So as a summary, homelessness is an important social determinant of health. It is a significant driver of utilization of public services. There's plenty of evidence that permanent supported housing is a promising approach both to combat homelessness and also improve outcomes in other sectors. But we also see that there's a big concern that there could be significant issues, implementation issues that limit the effectiveness of permanent supported housing. And we believe, based on the findings of our model, of all of our analysis, that Housing for Health approach to implementing permanent supported housing can improve outcomes for its clients above and beyond what can be achieved through the more traditional approach to implementing permanent supportive housing. So we believe this creates mechanisms that can help individuals escape the vicious cycles that make it difficult for them to live stable lives. And that it is a valuable model that should be explored further, that maybe can be reproduced in other jurisdictions. Thank you so much for your attention. Again, thanks to the System for Action Program for the invitation to tell you more about our work.
All right. Thank you so much, Ricardo. That was a lot to digest. But before we go to our questions from the audience, we'd like to first hear from our commentary speaker, Whitney. I'll turn it over to you.
Yeah, thank you, and thanks, Ricardo. I'll try to keep it brief. I see a lot of questions are coming in, and we probably won't have time to get to all of them. So my name is Whitney Lawrence. I'm the Director of Policy and Planning for Housing for Health. That means a lot of things, but it also means that I oversee our local rental subsidy program, the Flexible Housing Subsidy Pool. So I'm just going to give a few comments, and then I'll open it up for folks. So as you can sort of see, the scale of the problem that we face here in Los Angeles is pretty unprecedented. We are talking about 53,000 homeless folks for the HUD point-in-time count. That's sort of like an unprecedented amount of human suffering, a pretty massive misuse of our healthcare resources, and I mean, to put it bluntly, it costs a lot of money for us to do nothing about this problem, and absent an intervention, we are paying a lot of money to see people die on the streets. So sort of in response to that, Housing for Health was established as a unit within the Department of Health Services in 2012. We are basically the department's answer to being able to write a prescription for housing. Since we were established in 2012, we have grown exponentially year over year, and the cornerstone of our work is permanent supportive housing. And in case it wasn't clear earlier, permanent supportive housing is a rental subsidy paired with wraparound support services, a permanent rental subsidy with permanent wraparound support services. Our original goal at Housing for Health was to create 10,000 units of permanent supportive housing, and that sounded absolutely crazy at the time. We are now hovering just a little below 7,000 permanent supportive housing slots, and our new goal is to create 20,000 permanent supportive housing units by the end of 2022. We started with a very small number of medical recuperative care bed interim housing beds and a very small number of federal vouchers. We have since then grown into sort of like an end-to-end continuum of care that includes multidisciplinary outreach teams that are roving the streets of Los Angeles County engaging clients. We've got 1,800 plus interim housing beds. We have 8,000 plus permanent supportive housing slots. We also have rapid rehousing in our portfolio. We have a clinic right here on Skid Row where our offices are located that's providing health care for residents of Skid Row. We also have roving RN support that goes and visits clients in their units, and also an initiative focused on connecting clients to mainstream benefits. The sort of like the evaluation that you just learned about and the bodies of research like this analysis are absolutely critical to that growth and that success. And I just want to spend just a minute chatting about what we sort of ask of our providers. So I like to think, and I really believe that our success hinges on sort of like our three core philosophies, and those are harm reduction, housing first, and a whatever it takes approach. And that's really what we ask of our providers. In return, we sort of promise to our providers to be an atypical funder. We've incorporated enough funding streams into our work that we have the ability to be sort of funding source agnostic, which means we can sort of say, what does the client need first, and then we can figure out what is the most appropriate funding stream to bill that client against. The other thing I'll say is that we are sort of like a one-stop shop that can provide services and subsidy funding in one place. So if there are any funders on the call today, I really want to emphasize that this made a huge difference for our providers. They used to have to go shopping for services funding in one place, subsidy funding in another place, and kind of piece it together themselves. We've taken the guesswork out of it for them, and we've also set up easy contracting mechanisms. At the end of the day, what I want my service providers doing is I want them providing services to homeless clients to help us end homelessness in Los Angeles County. I don't want them getting really good at responding to RFPs every year. So we've tried to sort of like take that body of work out of it and let them focus on the real work. So as we continue to grow, we serve many more clients. I see folks are asking about the referral pathways. We are opening new referral pathways every day, including the coordinated entry system. And we're also recruiting and onboarding new providers all the time. So all those things and all of that growth mean it's absolutely critical that we continue to monitor the performance of our system, sort of like both in real time and with more detailed analysis like the one you just learned about. The last thing I'll say, and I say this to every group that I speak with, is that we are not interested in building programs here at DHS. We are building a system, an entire system, an end-to-end continuum that can meet clients where they are at, that includes a variety of care settings and sort of can meet the needs of clients as they evolve. I'm happy to follow up with folks and answer questions. I'll sort of get off my soapbox now because I know you have a lot of information and probably a lot of questions.
Thank you, Whitney. Yes, Ricardo did warn me that in advance that there will be a lot of questions directed both to you, especially about the program, and also to the study for Ricardo. So these questions are both for either Ricardo or Whitney to answer. Now, I do apologize. We have only 10 minutes left in the webinar, but whatever questions we can't get to, we will definitely forward them to Ricardo and Whitney, and they will get in touch with you. So let's start. There's a first question was how many units of housing for health did this create, and how much was the annual budget, I guess, for the period of this study, maybe?
So the study itself didn't create any units of permanent supportive housing, just to be clear. And I'm not sure sort of like at the time of the study how many spots we had, but at this current point in time, if we're just talking about permanent supportive housing, we're at about 8,000 permanent supportive housing spots right now. And we are growing exponentially every year.
Okay. So there was a question, what do you know about this frequent user systems engagement initiatives? They seem to be addressing at least some of the problems that you've mentioned. And the one who was asking the question would be interested to see how if few systems compare to Housing for Health. Are you familiar with that?
Yeah. And Ricardo, feel free to jump in if you feel motivated. But yeah, so I actually used to work at Corporation for Supportive Housing, CSH. And they sort of developed the frequent user system engagement model. And I agree with this question. I do actually think, and so for folks who don't know, the basic model is that you would target an intervention on high system utilizers. And every community can kind of, and every system kind of defines what a high utilizer is for themselves. Obviously within the healthcare system, it would be a high use of sort of like ER visits, for example, or very costly services. And I agree with the person who's asking the question. I think Housing for Health was not sort of like explicitly a fused project, but it is sort of like inherently a fused project because especially at the population we were focusing on at the time of this study, because of sort of like who we were focusing on.
So another question is Housing for Health only for those who are homeless, or is it available to those who are housing unstable or insecure?
Largely just for homeless folks. There have been some very rare exceptions to that, but largely just for homeless folks.
Is LA County doing anything to change or adjust other permanent supportive housing? Would you be aware of that?
Yeah, I mean, so my response to that is actually that we are now the largest permanent supportive housing provider in Los Angeles County, which probably means we are the largest, or at least one of the largest permanent supportive housing providers in the nation. So I think just sort of like by way of our scale and our impact that we are sort of like, we are changing the way that other permanent supportive housing programs do business. And it's also sort of like forums like this that allow us to sort of like take our show on the road a little bit. We present at conferences nationwide and are always happy as folks are considering sort of like if setting up a local rental subsidy program or if they want to replicate our model, we share everything. We can share our statement of work with our intensive case management service providers. We can share all of the information that we use to build that local rental subsidy program. So we are more than happy to engage with other communities as they sort of step into this body of work.
Cindy, chime in to that question. When we were recruiting participants for qualitative analysis, we actually had a bit of trouble finding service providers who were not Housing for Health providers, precisely like Whitney is saying. Housing for Health has become the largest provider of permanent supportive housing services in the county, and now it's pretty much any provider who's of permanent supportive housing services, they have involvement in housing for health activities. Given the findings of our study, obviously we are delighted that that is the case. It seems that we're moving in LA County essentially towards the housing for health model, which seems to have really great results.
There is a question, I guess it's more related to the study. Did other permanent supportive housing programs have a lot of people who were using the ER a lot before being enrolled? It seems like Housing for Health specifically identified people who were using the ER and inpatient a lot. Folks using other PHS programs may not have been in that top % at the start, and you wouldn't expect them to reduce ER use as much.
Yeah, that actually highlights the value of using the difference in differences approach for analysis, because we are controlling for those pre-existing differences in service utilization. So we're not just comparing the change from before to after for Housing for Health clients, but we're comparing that to the change from before to after for the clients of other programs. And so even if those differences existed before enrollment or moving, housing placement, our analysis controls for that. That said, I don't have the numbers in front of me, but I believe that the comparison group were also high realizers of health services.
Okay. There's a question on, is there a standard referral method for case managers to send participants to outpatient BHMH services? Is there a standard way to communicate with those outpatient services or to communicate with patient's primary care provider?
Yeah, I can answer that. The short answer is no. There is not a standard method for folks to refer to behavioral health or mental health. I think it's a real gap in the system, actually. We have sort of now the health agency in Los Angeles County is now sort of an integrated health agency. We're still sort of figuring out what that means, but that means we've now got the Department of Public Health, the Department of Mental Health, and the Department of Health Services under one umbrella agency. We're still figuring out what that means, but my hope is that these types of connections can be stronger. But the truth is that right now we really rely on our intensive case management service providers to make those connections for us. Of course, if the client is being seen at the Star Clinic here on Skid Row or at one of our DHS hospitals and clinics, then we have a little bit more ability to sort of like support our providers in making those connections, looking up if a client has an upcoming appointment or something like that. But not all of our clients continue to get health care through the Department of Health Services.
Okay. There's a question about the fuzzy cognitive map systems model. How was the map developed? Was it during the convening, or did it take a lot of activities, correspondence with stakeholders to finalize it? Curious to hear more about the process for stakeholder agreement on that model.
Yeah, I wish we have a systems engineering team who led the development of the simulation model. I wish she was here to answer that question. But so the short version is, the fuzzy cognitive map, I believe that's what it was called, was not developed during that convening. During the convening, we developed other types of charts that are sort of like this pathways for different sectors. We went back, or more like she went back, and started putting all of those charts together into this fuzzy cognitive map. There was some follow-up with some of the stakeholders, also, quite a bit of discussions among our internal team in terms of how to interpret what they told us during the convening. And the process, it took a few months to go from the participatory, the convening of the stakeholders, and having the final version of the map. Anyone who's interested, you can get in touch with me, and I'll get you in touch with the person who led this work. She can explain it much better than I can.
Excellent. We've got probably time for 2 more questions, and I again repeat that we'll forward these other questions that we weren't able to get to Whitney and Ricardo. So there's one question about, how do you approach homeless families? Is this program available only for individuals, or do you provide support to adults with children?
That's a great question. So when we first started, our work is primarily with single adults. However, over the course of the last 5 years, we've brought on a variety of funding streams. So we now are able to accommodate families within our structure, but it's still our primary focus is single adults.
Okay. And I guess we'll just choose the last question, I guess, in terms of next steps, in terms of this research, Ricardo. There's a question about, just remind again the barriers that were to obtaining health outcome data. What is the status of the data sharing? Are they continuing to pursue a pathway to obtain that data and assess impact on health outcomes?
Yeah, I mean, it's a really good question. I guess I didn't really explain why we didn't get it. So the data available in Next President Linkages project, this integrated data system that already exists in the county, includes service realization, but it did not have other data like lab tests, for example, or screenings for breast cancer, colorectal cancer, etc. So we were trying to get that additional data from health services to link it to the data we had in the Enterprise Linkages project. We basically just ran out of time. That's what happened. And you know, the DHS staff, they were willing to give us data, but they were overwhelmed with migrating a data system to a new enterprise system, and we were not able to get it. Unfortunately, because we're wrapping up the study at this moment, right now we don't have plans to look at the outcomes anymore. Hopefully, you know, either we or someone else will be able to take up that question in the near future.
All right. Well, thank you so much, Ricardo. Thank you so much, Whitney. We'd like to give thanks to our presenter and our commentary speaker and just the excellent work and research they've done. And we invite you also to look up at our upcoming webinars too here at Systems for Action. And so this webinar that you've listened to today and also past webinars are available for download if you're interested in learning more about them from the Systems for Action website. Again, we'd like to thank everyone who's joined us today, and we look forward to seeing you again soon. And have a great day.